Hello, everyone. I'm Lindsay Joseph, the LINCS Program Officer, and I'd like to welcome you to the second LINCS webinar on COVID-19 and the global health community, the global cardiovascular health community. A few housekeeping rules before we begin. The presentations will be about 30 minutes, followed by a Q&A session. All attendees will be muted for the duration of the webinar, but you will have the opportunity to type in questions using the Q&A button at the bottom of your screen. Please use the Q&A button and not the chat feature to type in your questions. I will now hand it over to Dr. Andrew Moran, Resolve to Save Lives Director of the Global Hypertension Program, to give an overview of what we do in the hypertension program, as well as introduce today's speakers. Andrew?
Yeah, thank you, Lindsay. So I'm going to show just a couple of slides to get us started. We are taking several measures to take part in the Vital Strategies COVID-19 response. And as you see, I was just going over, we're providing the epidemiology support for questions related to the intersection of cardiovascular health and COVID-19. We're defining and promoting best practices to protect cardiovascular disease and other chronic disease patients. And these include longer duration prescriptions, medication delivery in the community, primary healthcare facility redesign, and development of telemedicine capability. And we're also, as part of that last piece of the telemedicine capability, expanding the Simple app, which is the hypertension management app we are using in the India Hypertension Control Initiative, to include telemedicine management capacity. And just to show you some of the materials that we're developing, you can see these on the LINCS website in terms of protecting chronic disease patients. You can also, soon we'll be sharing the primary health center redesign recommendations. And this is a floor plan of a primary health center showing a design that triages patients with suspected COVID-19 symptoms so that they're kept away from the primary health center where chronic disease services are delivered. And also just want to give you a couple of screenshots of prototypes of the Simple app that are being developed for telemedicine. And with that, I'm going to hand over the microphone to some of our country directors for some country updates. Lindsay, you can take over.
Thanks, Andrew. And now we will have a presentation from our India country team lead, Dr. Bhavna Sharma.
Thank you, Lindsay. I would like to give a situation update from India. Next slide. As you can see, the first case was reported in March in India. And by 22nd March, we had 500 cases, and India decided to actually lock down all of India. But still, even with the lockdown and a lot of contact tracing and initiatives in India, we have been able to not have a peak, but buy time to actually upgrade our facilities to be able to combat COVID cases. So we have actually reached up to 78,000 cases as of now in India. And we have almost a doubling time of 12 days at the moment. But we are not seeing any decrease in the number of cases coming. The only thing which has helped India is that the lockdown has not made any peak in India. So we have been able to cater to all the patients who have been coming to the health facilities. Next. And we have been able to control the death rate also. We have just 3,000 deaths till now. The distribution of COVID-19 in India, as you know, India is a big country, and we have states in India, 31 states in India, and we have differential distribution of COVID-19 cases across the states. 10 states in India are approximately having the 90% of case loads. You can see the darker shade states, the darker areas are more than 8,000 cases have been reported from there since now. And the other lighter states, there are states in India which have not reported any cases, like the northeastern states of Arunachal Pradesh, Sikkim, and Manipur. So we have very differential distribution of COVID-19 cases. Next slide. Next, yeah. So in COVID-19, what has India done? We have bought time to actually buy in to redistribute the healthcare system. So we have been in lockdown since 24th of March, but since 1st of May, there has been a loosening of the lockdown. And how are we loosening up? The whole country cannot be in the lockdown for a very long time because we have a very fragile economy. So what has happened is that the whole of India has been divided into risk zones. There are red hotspots where there are maximum numbers of cases being reported, like from Mumbai and Delhi. These are the hotspots right now in India, where lots of cases are being reported. So they are really being, movement is restricted. In these cities also, there are containment areas where actually the COVID cases are in cluster. So they have been containment area where no movement is allowed. Then we have a surveillance throughout the country because some of the states are really reporting very low cases, in which we are monitoring any kind of upper respiratory tract infections or influenza-like syndrome, which are coming throughout the country, to monitor outbreaks and identify the areas where maybe COVID is coming. So what has happened is India has slowly opening the essential industries. There is to balance the work and health. And 33% of people have started working. Next slide. So what did India do during this time? During this time, India developed the strategies. We have now designated COVID hospitals in the cities, and we have demarcated sections in smaller public health facilities at the smaller village level, so that we can actually cater to all the patients at all levels of areas. Then we have fever clinics to protect the facilities from being overburdened and coming in contact with all the patients in the hospital. Then we have a very big migratory population who moves from one state to another, and even from outside the country, quite a few people are coming back. So we actually have special quarantining facilities for them, where they are kept in the quarantine facilities, and especially in the areas which are green zone, where we have not had any COVID cases till now. Then there is a very big mobilization, community mobilization, and through education for home quarantining, people who are suspected or even at risk people are asked to quarantine at home, because you cannot develop health facilities for them. Then we have an availability of a specialist decks. That means the super specialty physicians who have been treating COVID for the last 2 months, the smaller places, physicians can actually have there is a call center, a telephone number, whereby they can talk to the senior physicians to take care of the COVID patients. Next. Then India has, in the last 2 months, has taken a very need-based approach. For our, there is an app, a telephone application which has been, Arogya Setu has been developed, in which any citizen of India can download that app and actually can see who are the people around in that area suffering from COVID. You can do contact tracing if the COVID patient gets registers in that, and it provides educational materials on COVID, on how to protect yourself to the normal citizens. And since in India most of the people have a telephone, this can be easily taken care of. Then ventilators, which is a primary requirement for any of patient care, The ventilators have been started manufacturing locally, protective gears have been manufactured locally, and even the testing kits are being produced in India. Next. So for Continuum, for the non-communicable diseases in India, the policy decision has been taken that the medicines can be dispensed by the community health workers, which are called as ANMs and ASHAs in India. They can dispense the dispense medicines for known hypertensive, diabetic, and other ailments patients. It can be done for 1 to 3 months, since it's a public health system distribution system. Depending on the availability of the medicines, the ASHAs and ANMs can deliver. Then there is to promote and protect the health facilities, telemedicine is being promoted at all levels in India. Next. So for COVID response, we have been sharing all our Prevent Epidemics weekly reviews and translation. Next, translations of all the material has been done in Indian languages and been shared with our partners. Next. Because we have many languages in India, you can see the material has been translated into many languages for easy availability at the ground level. Thank you.
Thank you, Bhavna. And now we will have our country team lead, Xiao Ying, give a situation report on events in China.
Hello, good morning, good afternoon, and good evening. This is Hao Ying from China team. And I would like to share some slides about China's progress. As you all know, in last December, a cluster of acute respiratory illness, now known as the COVID-19, occurred in Wuhan, Hubei province, China. On December 31st, the Wuhan local authority already reported 27 local cases. The disease has rapidly spread from Wuhan to other areas. And as of January 31st, a total of 9,000 cases have been confirmed. And up to now, in mainland China, the total confirmed case are more than 80,000 with 4,633 deaths. Next, please. Here, the bar chart shows daily confirmed case number and the trend in the past months. Basically speaking, China's data is highly driven by Hubei province data, especially driven by Wuhan city's data, since it is the only epidemic center. The rest of country has not experienced from epidemic, which is benefited from the national lockdown during January 25th and early February, thanks to the Chinese New Year holiday. Next, please. Here we would like to present some key actions through January and February, the Titan phase. They mainly focus on, first, lockdown. Second, the government provide hospitalized services to all confirmed cases, including set up 2 new hospitals and 16 camping hospitals. And 55 general hospitals transit to fighting with the COVID-19. And health professionals categorize the different health facilities into different, for different level of disease. For example, the camping hospitals only admit mild cases. At the same time, National Health Insurance announced the treatment will be supported by the insurance scheme. The next thing is, in China, the government to ask the whole population to do the centralized quarantine for all suspected and probable case. And at the same time, we do home-based or centralized quarantine to close contacts. community level health workers and community leaders will do the follow-up services to monitoring all of the close contacts, the progress of their disease or the health situations changes. PCR testing and the contact tracing is continuously expanding in China. At the peak point, Wuhan city had more than 1,800 contact tracing teams working in the field, with every team have 5 persons. And for a very long time, within China, the travelers need to do mandatory quarantine after they traveling. Next, please. Starting from February, China entered the suppression phase. The whole society was going to reopen, but in a very slow way. And we will see the first province announced downgrade the emergency response level from the first level to the second level was on February 21st. But until May the 2nd, all of the provinces in China canceled the level first emergency response. So the downgrade speed does not really match epidemic data, which shows open up decision making is influenced by multiple concerns and not only the decision for the epidemic evidence. At the same time, we will see that basic health services such as immunization, maternal and child health care, NCD are resuming very slowly. In terms of imported case accounted for 46% of total in March and 87% in April. The National Ministry of Foreign Affairs announced a temporary canceling visa for all foreigners. And the international flights are limited. We also closed the land border with Russia. Chinese citizens returning from other countries are ordered to do the mandatory centralized quarantine. At the same time, the contact tracing is continued and the temperature checking is continued, and the PCR testing is expanding. People are encouraged to wearing masks in public areas and also to use the health QR code on their mobile phone. I think before I go, I'd like to share that because we don't really understand the virus completely, things could change very quickly. For one example, currently in Shulan, a very small city of northern China, starting from May the 7th, the first local case was reported locally, and local government could not identify its infection chain. Until today, local confirmed case increased to 22. So my point is, we need to think about living with the virus until the vaccine available. Yeah, thank you all.
Thank you, Xiaoying. Next, we have a situation report from Ethiopia given by our country team lead, Dawit Bisrath.
Hi everyone, Dawit here. Next slide, please. So on March 12th, we detected the first case who was a Japanese diplomat who came to Ethiopia to support the Ministry of Education. And he was the first case that we detected in Ethiopia. On January 27th, the Ethiopian Public Health Institution activated the Public Health Emergency Operation Center, and daily monitoring tools were developed, and the IMS section was leading this coordination. Next slide. On March 28, one of the regional states in Ethiopia imposed travel restriction separately, And after 3 days, the other regional states declared a lockdown because we detect one case in that specific region, so other than Addis. And on March 25, the government decided federal employees has to, 50% of the federal employees to work from home, 50% to come to the office. Next slide, please. That was the preparedness, and the current situation is so far as of today, we have 272 patients. This was yesterday's data. Today we have 9 new cases, and the total number of patients recovered are 108, and we have more than 157 active cases. The total deaths so far are 5. Next slide. And one of the effective responses is that we have been like tracing contacts for those who are infected, but also we were trying to search. We're conducting active patient search by sending community health workers house to house. So these are the 4,500 people are traced because they had contact history with travelers or with known positive individuals. Next slide. So initially, we were thinking that what happened in Italy, in Spain, and in New York would happen in Ethiopia, but that's not the case. The total number of cases that we have in Ethiopia are 272 as of today, and the number are very small. So it's not because our effort has a lot of contribution, but because of other unexplained issues, we have a very small number of patients. But the good practices, the good things that we have implemented during this COVID pandemic is the contact tracing. Online training modules started. So face-to-face is almost excluded from the program. Resource allocation from the government has increased significantly. So public funds are allocated for the COVID, which doesn't happen during the normal situation. So we wanted to sustain. Innovation become very encouraging. So people start to develop mask, face shield, apron, and foot pump. This is very important, and we want those things to be sustained because a lot of people in Ethiopia die because of diarrhea and abdominal infections. So the hand washing has significantly decreased the occurrence of diarrhea. The other thing is, the very important thing is the community health workers are engaged in like remote collection and informing to the call center. At the same time, they are going house to house to find active patients. So they go to house, they ask them the family members' history, they measure their temperature when the infrared temperature machine is available. Next slide. So the challenges that we have regarding to COVID is we have a very low testing rate. So people are refused to come to get tested. The number of patient flows to hospitals has significantly decreased. That's because that is because of the stigma, and some people think that when they go to the hospital, they will test them for COVID without their knowledge, and a lot of people also think that the health facilities are only available or open for COVID. So 2 mothers has died because of this, because they don't know that the essential services are open in the facilities. So they didn't go to hospital, so they died because of bleeding during labor. The patient flow is decreased, like I said. We have limitation of resource. At the same time, individuals do not personalize risk. So we did the non-pharmaceutical intervention key poll survey. So based on the evidences, the findings that we have collected from this poll, 75% of the respondents think that they are not at risk. It's because most of them say it because they trust in God, and some of them say it because they are young and fit. That's another challenge. And the socio-economy is also another challenge because the government couldn't implement the NPI. One, because the number of patients that we have are very small. And again, secondly, then we have millions of daily laborers and individuals who work in very small scale business. So that affects a lot. And during our NPI study, majority of them say that they don't have, they will run out of money in a week if they don't work. And they will run out of money in a week, out of food in a week. And those who have medication or individuals with chronic illness, they say they will run, majority of them said they will run out of medication in a week time. So because of all these things, the government couldn't implement the NPI, but partially they were trying to advise and educate the public to wear masks and wash hands, and then to keep their physical distance. And we contribute a lot in developing risk communication messages on this regard. Next slide. So what does Vital Strategy and Resolve Save Lives support on the COVID? So we work a lot, we support them a lot in risk communication. We develop TV and radio ads, same time banners and other education materials together with the Federal Ministry of Health and EPHI. We also design a methodology to engage the community, especially to report individuals who have sign and symptom and who have a travel history before the mandatory quarantine was strengthening. Second one is, like I said, the house-to-house active patient searching. The active surveillance was very important. So we visited more than 4 million households throughout the country. We send community health workers to go house to house, to their catchment area actually, and are combined by health professionals and law enforcement people. The third one is the essential service. So initially, like I said, we were thinking the same, what happened in Italy and Spain would happen in Ethiopia, but that's not the case because of different reasons. So now we engage the Federal Ministry of Health, the regions, to also focus on the essential services. So ours is hypertension, but we developed a manual, a guideline for essential services. So the regional health bureaus are now leading this. We initiated it, but we hand over to them because they have to own it. So we are working on this one. And we are planning to start telemedicine. That's on the process, and we have developed a guideline for Ethiopia, which customized from the one that the Indians and our HQ team developed, and we are working on that. The primary healthcare worker training on IPC and surveillance is also ongoing. So far, we have trained 600 TOT, and those TOT trained staff will cascade it to primary healthcare units in their adjacent health facilities. So we will also donate PPE materials for those we trained, and we have a checklist to follow up with their progress and their gaps, and then we'll intervene according to the findings. Next slide. So activities in progress. One is telemedicine. We are almost there. So we have also included the cardiac society in Ethiopia and the cardiologists in the big universities, because those are also decision makers in when we come to developing protocols. So for Resolve Save Lives sites, we have an approved protocol that approved by the Federal Ministry of Health, but it's not endorsed nationally. So we are working on that with them. So the telemedicine will focus on that. The second one is we are planning to engage the FLTP NCD track to work with us on hypertension COVID related activities. So they will also help us on the telemedicine and data analysis and surveillance. for NCD, I mean for hypertension. Same time, we are working on salt reduction message development because we have staff who are working on this. And we are also analyzing the CAP survey on salt reduction that we have collected a month ago. Next slide. And then we have translated these materials into 4 Ethiopian local languages. We sent some of them for designing, but these are the ones that are approved. So we are planning to send it. The English version is already distributed through the risk communication, the National COVID Risk Communication Team. And these translated ones will be disseminated through our regional coordinator, the Federal Ministry of Health, media outlets, and through the media communication, that the risk communication that we are working with at the Ethiopian Public Health Institution. Thank you so much.
Thank you, Jawed. And lastly, we have our situation report from Nigeria given by our country team lead, Dr. Emmanuel Ogogo.
Hello, good day, everyone. Next slide, please. Just a bit of an individual follow-up. 27th of February, we had the first case that came into Nigeria, someone who traveled from Italy, an engineer, traveled to another one of the states, and from there he was taken ill, and he was seen by one of the doctors there, and a suspicion was made. He was moved back to Lagos from Ogun, where he was, and they tested, and he was found to be positive. Subsequently, the Nigeria Center for Disease Control, that is at the national level, was activated on the 28th of February, and then on the 9th of March, in response to this, with cases escalating, the presidential task force was set up. So the organization, the response to the COVID-19 outbreak pandemic in Nigeria is organized at various levels. We have the presidential task force that is chaired by the number 3 government official and comprises all the key ministries, and we also have a response at the Nigeria Center for Disease Control that provides the technical insight and support, and that's really where our work for Resolve is focused in Nigeria. Unlike the other countries, 80% of our work in Nigeria is focused on epidemic preparedness. And on the 1st of April, the federal government decided to lock down in 3 states with the highest burden of disease: Lagos, Ogun, and the Federal Capital Territory. It's important to note that Lagos and the FCT have the busiest airports, and so we found that a lot of the patients who came in through these ports, and Ogun is just a stone's throw from Lagos State. Once the president did that and extended 2 iterations, states also followed suit, I think a week after the presidential lockdowns, and most of the states have now instituted a ban in interstate travel, and at the moment we still have a complete ban or lockdown in those 3 locations. That's Lagos, Ogun, FCT, and Kano, which has emerged as another epicenter of the outbreak. Next slide, please. So this is just a summary of the numbers. If you like you to look at the colored boxes, so we have just about under 30,000 samples tested in total. We have with just under 5,000 confirmed cases, a case fatality about 3%, and about 1,000 patients discharged. I didn't include this slide, but the age demographics has slightly changed. At the initial stage, it was obviously majority men of a certain age, over 50 and 60, but now the average age has come down to about in the 30s and 40s, especially since we're now seeing more of a community transmission. Just to take your attention to the CFR of 3%. Obviously, I think we're not sure, but it's a likelihood around the demographics. A lot of the patients who have passed on are patients who have comorbidities, majorly hypertension, diabetes. We have had some with HIV and with other causes of immunosuppression. these are really the drivers of the mortality. We've had less than 5 deaths in people under 19. Next slide. So this is just what I was saying earlier. So the majority of cases are male. Majority affected group at about 20, 31 to 40-year-olds. Nigeria has been experienced with managing outbreaks. So while this has been going on, the huge outbreak of Lassa fever started end of last year. And ended, and the emergency EOC was just disbanded about a couple of weeks ago. Essentially, what has happened is that because of these outbreaks of Lassa fever, yellow fever, and meningitis in the last few years, the knowledge and expertise around contact tracing is quite well developed, and so the systems are in place. There's an electronic platform called SOMAS that is used to do case-based investigations. And therefore, we kind of quite close in looking at the overview of the cases. We were able to notice when the transition occurred from imported cases to mainly community transmission. And you can see from the pie chart that 65% of the cases at the moment are obviously those without an epidemiological link, and that makes it quite clear that we have established community transmission in the country. Next slide, please. And the high contact tracing rates of 98% is really because from the word go, people of interest as they came into the country were identified. They were screened at the airports with temperature charts. They were now sent home on isolation. They were now isolated. Some were isolated at home, and all were giving a COVID care kit where they had the thermometer and temperature charting to monitor their temperatures, and then they were calling if they developed symptoms. This next picture is really the map of Nigeria. It shows you how complex it is. It's 36 states plus the FCT, the Federal Capital Territory. Each of these entities have their own governors and have their own jurisdiction over the healthcare system in those countries in those states, because health is on the concurrent list. And therefore, at the national level, there is some support and control, but the control is a bit limited because at the state level, they do have their responsibilities to manage health systems in those states. 2 of the states have, not been very open to testing and to receiving public health officials. The epicenter of the outbreak has been clearly Kano, is emerging as the next big epicenter, and Lagos has really been this place where in the southwest of Nigeria is really the place where you've had a lot of the cases. One of the things that has worked well in Lagos is that after 2 weeks of identifying cases, there was an active case search where there was a massive house-to-house testing and screening of people, and individuals who met the case definition were offered testing. And Lagos and Ogun have been the places where innovations have come through in terms of having drive-through testing centers, and also developing prototype sample testing buses that are rigged in a way that it reduces the risk to healthcare workers. Next slide, please. In terms of what I said already, RT's rapid response teams have been deployed to all the states of the Federation just to enhance the NCDC's role. That's the National Center for Diseases role to support and the states at the state level. Each state is structured and have their own, like I said, a governor, commissioner for health, director of public health, and a state epidemiologist, and they are supposed to, coordinate the response at the state level. But these RTs have gone to provide technical assistance and sometimes lead some of the teams to identify the first few cases and help review systems that are in place. With the advent of COVID-19, I'm sure you've all seen reports globally in global papers around the shortage of access to ventilators and isolation facilities and so on in countries in Africa. I think Nigeria has been no exception. But since the COVID-19 outbreak, there's been a huge ramp up in terms of identifying new facilities to to provide both isolation and ICU beds, and there's been a drive to scale up accessibility of ventilators, of course, to nowhere to numbers just south of 500. So across the whole country, we've not had a huge investment in the past in ventilators, and that's really showing up now. Fortunately, the majority of cases so far have there have not been the volume of cases that have required intense ventilator support. The other thing that has also happened, and I missed that from this slide, has been the scale up of laboratory testing. So there was a national laboratory testing strategy that we supported the development of, and that now introduces testing through different modalities and trying to scale up from a situation where only two labs could test in 2 weeks at the outset of the outbreak, to now having about 22 facilities that can test using open platforms, and then repurposing high throughput machines manufactured by Roche and Abbott to do testing, high throughput testing across the country. So, and then the last layer of intervention has been to begin to look at how to bring on board GeneXpert to do testing at the state level, to bring testing closer to the facilities. So while these facilities have been upgraded and the testing is being done, the challenge really is around access to the testing reagents and to testing reagents, as well as to the test kits, because of the global shortage and the fact that it's all coming from the same global pot. As we speak, contact tracing activities are still ongoing in those, especially in those states where we're beginning to see a spiking of cases, and therefore the guidance is also been there's a series of guidance that have been developed in various areas, including health, home care, how businesses can reopen, guidance in terms of case management, which was recently reviewed, guidance to religious homes and so on, and so quite a lot of guidance has gone out from NCDs to the state and to various sectors to help them be more effective. The country did a first over the last weekend where they a mid-action review was conducted. So it wasn't a process of reviewing the outbreak, reviewing the incident action plan that's been developed, reviewing the strategies so far, especially since things are moving from a containment mode to community transmission. Next slide, please. Yeah, so of course challenges remain. I wouldn't dwell on
Emmanuel, if you could wrap up, because we want to leave 15 minutes for questions and answers. Thank you.
Yeah, so I'm actually done now, thanks. So just the challenges which are always there. Next slide, please. Next slide. So Resolve has been providing technical support to most of the pillars at the EOC. The Outbreak Revolving Fund has been very useful in helping the RTs to be deployed. We're planning some work around healthcare training primary healthcare workers on IPC and case management, and also doing some work rolling out mortality surveillance. The legal work has really helped in trying to address the MPI interventions in the country. Next slide, please. Next slide. Okay, just some risk communication materials have been developed. They haven't been translated to local languages yet. That will be the next stage, and these are now being pushed out. Have been developed in collaboration with the Ministry of Health and the WHO. Next and final slide just shows some examples of local and next slide, please. Next slide. So this is just some examples of interventions that people have developed in Lagos State, for instance. Same as in other countries around, long-term prescription, giving long-term prescriptions out, and then adopting telemedicine in government facilities. This is also happening in the private sector, although there are pockets and it's not like a national system. Thank you very much for listening. Over.
Thank you, Emmanuel. We are now going to open it up for questions and the question and answer session. Please use the Q&A button located at the bottom of your screen in order to type in questions. Before we get started, I've seen a few questions in the chat relating to educational materials. All of the materials that were shared as far as flyers for health facilities are available on the LINCS website, available to the public. We strongly encourage you to use these materials and translate them to your local language and distribute as needed. These are available to the public, and we strongly encourage people to use them. We had a few questions that were submitted in advance. I can display them on the screen here and open it up to our panelists to tackle some of these questions. The first one being, many countries have seen disruption of essential chronic care services due to COVID-19. What are the criteria for resuming routine primary health care in your country? Perhaps we can start with Dr. Bhavna.
Thank you, Lindsay. Yes, in India, we have actually demarcating areas for people coming with fever so that they do not disrupt all the other activities in the primary health center, and all the other chronic care patients and antenatal care and vaccinations can go along simultaneously. So therefore, even in the very small primary health centers, areas are being demarcated for fever patients and for the other patients. But it has been seen that due to the COVID situation, people are scared to come to the health facilities. So the footfall in the facilities have really fallen. Maybe it's because of the lockdown. And so slowly, I think the footfall will increase. Thank you. Over to you, Lindsay.
Thank you. The next question, telemedicine has been promoted by many country governments. For those of you who have who talked about using telemedicine or the adaptation of different apps, perhaps you could speak to how this function has changed and who's using telemedicine, healthcare providers and patients, and how helpful it has been.
In India, we have a government telemedicine hub, but how much it is being utilized as of now, it's very early stages, because the telemedicine guidelines have been changed very recently. So it was not being used very extensively before. So as of now, it has been started in certain states where certain calling, it's basically at the sub-center level. That means the health provider calls up the doctor and the patient is given then the patient and the doctor can talk. There is an app which is also being developed where the patient can actually call the provider directly. But still we are in too early stages to even tell you how it's going to change the way we look at healthcare. But it is starting up and patients are calling. Even the healthcare providers are talking to the senior physicians and delivering the care, healthcare at the smaller facilities.
Anything to add, Emmanuel or Dominic?
The telemedicine work in Nigeria is mainly private sector driven. So a few private hospitals, mostly the ones in urban centers, have rolled out the telemedicine services to their patients. I have some anecdotal evidence of this. But also the government has been talking about this, but there has been no structured national framework to do telemedicine yet. Over.
Thank you. There's a question for you, Emmanuel, in the chat. Recently in Nigeria, there are challenges with availability of beds to admit patients. What initiatives are available to cope with the number of patients demanding beds?
Okay, so there's been an introduction of, almost a dichotomy between isolation centers for milder cases as well as, beds for more severe patients. So for isolation centers, we've seen the use of youth camps, we've seen the use of hotels, we've seen the use of other big public, like for instance, one of the stadia has been converted in Abuja to provide 300 beds for people for isolation. So that has been done. Then the other thing in terms of specifics is that for more severe patients is that there's been scale up of building ICUs and trying to build in equipment, which of course is limited by these issues. The other thing that's also helping now is the introduction of the home care guidance, which should reduce the need for mild cases, specifically low risk cases having to be managed in hospital. Over.
Great, thank you. Dr. Bhavna, there was a question about the fever clinics, and if you could speak a little bit about how that has been received in India.
In India, it is being tried at big hospitals and bigger cities as of now. And this has been taken care of, that if you enter the hospital first, your fever is checked, and then you are sent to the required physician at the entrance. But how is how the patients are receiving, accepting it's right now very difficult to say because no data has come in. But I think most of the people with all the knowledge which has imparted, most of the people are aware of it and they will follow the path.
Thank you. Thank you.
Hello, this is from China. In China, we also have this kind of fever clinic after 2003 SARS epidemic, and this fever clinic usually is standing alone outside of the standard health facilities, and to separate the patient with fever to an independent area, and to reduce the potential infection between different patients. So it actually works.
Great, thank you, Xiaoying. We have time for one or two more questions if people would like to type into the chat, or we can refer back to questions submitted in advance.
I think this is David here from Ethiopia. I want to address a plate number, the third bullet. That says there is a concern that patients with acute, urgent, and COVID conditions are avoiding or cannot access healthcare facilities. So what we do in Ethiopia is in each district, we have one health facility dedicated to COVID. The remaining health facilities are non-COVID, but the public doesn't know that the non-COVID health facilities exist and essential services are available. So once we understood this as a vital, resolve to save lives and with vital strategy with the communication team, we are developing risk communication and a message that educates the people that essential services are available and they are not going together with the COVID patients. So we have a different special health facilities for COVID, and the rest of the health facilities are open for any essential service. So we are educating the community. We are developing also different messages to broadcast them through their local FM radio stations. Over.
Wow, that's great. Sorry, we're pressed for time, and before we wrap up, I wanted to give our panelists just a few more minutes to add any final remarks before we close.
I saw there's one question specifically about telemedicine in China. I would like to respond in a quick way. Telemedicine in China have been, I think, developed for more than 10 years, and there's a lot of different challenges here. And during the COVID-19, especially in Wuhan and city, the innovation way is to how to cooperate with the B2B IT company, and to use their delivery services to provide those medicines ordered online, and to deliver through the delivery service direct to send the medicine back to the patient. So it's very efficient, and it's kind of a new thing currently in China. Over.
Thank you, Xiaoying. Any final comments from any of our other panelists?
Yeah, this is David.
Yes,
sorry. Yeah, in Ethiopia, like I said, the number of COVID patients we have are very small. So we are shifting from balancing the essential services and COVID to prioritize non-essential services. A lot of patients are dying of at this time from like cholera and malnutrition and malaria in Ethiopia. The total number of deaths that we have from COVID is 5. So the government is now focusing on working with this essential service, including NCD and the other infectious diseases, including malaria, malnutrition, and other local infectious diseases. Yeah, over.
Yeah, just the last thought from me is the fact that I think with what we're seeing in terms of the overlap between non-communicable diseases and mortality in COVID-19, I think that it's an opportunity to really get countries to be more aware and to invest more and to increase awareness about NCDs. So I think there's an opportunity to really push forward on this. Thank you.
Well, thanks to all of our panelists this morning or evening for some of you, and thanks to all who attended this live session. You know, it's challenging to continue the work that we're doing given the circumstances, but I really appreciate your involvement in today's webinar. The next LINCS webinar will be on June 18th. The topic will be the environmental determinants of hypertension, presented by Dr. Prabhakar from the World Hypertension Federation. This webinar has been recorded and will be posted to the LINCS website along with the slide presentations from our presenters in the next day or so. Thanks again for all who, the World Heart Federation. Thanks again for all who attended, and we'll be in touch soon.
Thanks everyone.
Thank you. Thank you.